we'll get started on a topic that I'm sure will be of interest to everyone, possibly something you're dealing with every day, chronic condition with some pretty serious consequences that needs some thoughtful management. And here to talk about that, we've got Professor Ralph Stewart, who's a cardiologist at Auckland Hospital and at the Auckland Heart Group. So welcome, Ralph, and I'll hand it over to you.
Thank you, Vicky, and welcome everybody. As Vicky has said, atrial fibrillation is a very common problem, both in cardiology and in primary care, where it's a lot of the management needs to be. So what we thought we'd do is take a case-based approach. We've got 3 cases, and hopefully that'll raise lots of questions for discussion. So the first case is a 72-year-old woman. She has a history of hypertension. She's on treatment with Cilazapril, and she's feeling fine when she comes to see you for some other reason, but you find that she's got irregular pulse. So the question is, what are the next steps? Obviously, an irregular pulse could be due to atrial fibrillation. So what are the steps that need to be taken, and what do we need to think about? So I'll go on to the next slide.
There we go.
Okay, so the first step is to confirm that the diagnosis is actually atrial fibrillation, and you really need to do this on an ECG. It's actually very easy to be misled by the pulse alone. For example, ectopic beats, which would be another common cause of irregularity, can feel not too dissimilar to atrial fibrillation. So you need to do an ECG, and here's just an example here. And the things you look at are, first of all, the absence of P waves, and you can see at the baseline here is sort of quite irregular and jagged, representing chaotic atrial activity. But sometimes if the ECG quality isn't that great, you might not be able to see the P waves that well, and the baseline can look irregular. So the other key thing to look at is the distance between the QRS complexes, and so often I do this with a bit of paper, and you measure one distance and then the next and then the next, and if you do that, you'll see that the distance is totally irregular. It's irregularly irregular, and that's usually enough to confirm that the diagnosis is atrial fibrillation. So that's obviously key, and ideally we'd like a 12-lead ECG, because while an ECG, the first step I guess is further diagnosis on the rhythm strip, but the 12-lead ECG gives more information about possible underlying structural heart disease, which is one of the key questions. So having made the diagnosis, and these are the things that we might consider. So the first thing is, why is the patient in atrial fibrillation? And we'll come to possible reasons in a minute, and there's quite a large number of them. The next thing, which is very important, is this patient at risk of having a stroke because of the thrombo-embolic risk that atrial fibrillation carries, and should she be on an anticoagulant? And the third thing is the heart rate, do we need to do anything to stop the heart going too fast? So what tends to happen with atrial fibrillation is that the ventricular rate tends to be very much faster than usual, and it would be even faster if the person's under exercise or stress than it normally would be. And so and a lot of the symptoms related to atrial fibrillation are due to that fast heart rhythm. So do you need to use a drug that slows the heart rhythm down or not? And this patient's asymptomatic, so that's obviously, that might be one reason that you don't have to worry about it, but there might be another one. And then the next question is, do you need to consider whether to try to get this person back into the normal rhythm or sinus rhythm? So they're the things to consider. So let's take one at a time, and there may be questions as we go along. So why is she in atrial fibrillation? So the things to think of, I guess, I've probably got them in the upside down order here, but I guess the first thing I think of is there an underlying cardiac disease that might increase the risk? And any disease which increases the atrial pressure or stretch acutely or over time will increase the risk of atrial fibrillation. So the diseases that do that most are things like mitral valve disease or heart failure, but hypertension is another common thing which will do it, and acute myocardial infarction, coronary artery disease. So basically, most cardiac diseases might increase the risk, and also it might be that atrial fibrillation is the first clue to the presence of some underlying cardiac disease. So it's important for two reasons. Is there something that we have to, is there a cardiac problem that might be relevant to the occurrence of atrial fibrillation, but also is this atrial fibrillation a clue to the presence of some problem that may mean that management is of its own right. So as you know, the first steps to that are a clinical examination, a full cardiac examination, a 12-lead ECG, and then you may want to consider a chest X-ray, referral for an echocardiogram. So most guidelines say that a patient with atrial fibrillation who hasn't been evaluated mostly should have an echocardiogram. There might be a few situations where that's not necessary. And then the question of cardiology referral, and that's a harder one. But if there's a suspicion of an underlying cardiac problem, and which treatment may be important for the patient, then that would be appropriate. And then the other things we think about are intercurrent illness. So very commonly there would be infection. So urinary tract infection or a chest infection might be the trigger. Although I think in these cases, often the patient would probably have an underlying tendency to atrial fibrillation anyway, but the infection might have been the trigger. So it doesn't obviate the consideration of other factors. Acute pulmonary embolism is one cause of atrial fibrillation, but you'd normally expect the person to be suddenly not so well and short of breath. And then the disease, although I think it's usually pretty obvious when it's there, but definitely worth thinking about, is thyroid disease. So hypothyroidism can be manifest as atrial fibrillation, often rapid atrial fibrillation. So how are we going here? We haven't got thousands of questions so far, so that's now the other thing to think about atrial fibrillation, and maybe a more important thing in younger patients, but everybody really, is are there lifestyle factors that are important in triggering the atrial fibrillation? And the classic one is alcohol. So binge drinking with a hard night on the town can be a trigger for atrial fibrillation in people who have otherwise a normal heart. And if you've got a tendency to atrial fibrillation, excess alcohol can definitely be a factor that's important. Stress, interestingly, is quite an important trigger for atrial fibrillation. They did a very interesting study in Christchurch, actually, where they were looking at how the earthquake, what was the effect of the earthquake on heart disease, and it did cause a number of cardiac problems, but the biggest one actually was atrial fibrillation. So acute severe stress of whatever cause can be a trigger for atrial fibrillation, and may be relevant, obviously, to the management of individual patients. And obesity is a risk factor, so and probably one of the drivers for the increasing prevalence of atrial fibrillation, and that might be by a number of different mechanisms, but increased pulmonary hypertension, hypoventilation syndrome, but other mechanisms as well. And the interest there is that there have been studies recently which have suggested that lifestyle management and diet and exercise and reducing obesity can reduce risk of recurrent atrial fibrillation. People have paroxysmal atrial fibrillation. And then exercise links into that as well. So if people who don't do any exercise are at higher risk of atrial fibrillation than those who do, but exercise can also be a trigger as well. So that's one situation where atrial fibrillation might might be a trigger. Particularly if people have worked outside a hot day, vigorous exercise, that not uncommonly is a trigger.
Would caffeine be a trigger?
Yes, I mean, theoretically, you'd expect caffeine to be a trigger, but for practical purposes, we hardly see that.
Right.
And I think that it's unusual to be a major factor. It's quite not uncommon that caffeine can be a trigger for ectopic beats in some people and palpitations, but for most people, I guess if you've got a person who drinks large amounts of caffeine and they go into atrial fibrillation, you might wonder if that might be a factor. But probably for most people who most people, it's probably not important.
Yeah. Okay. And another question is low B12. Is that something you consider as a known trigger?
I'm not aware of that as a trigger. That's a good question. I don't know if that's a trigger.
And just some questions about any other medications and whether or not they'd be any known medications.
Well, methamphetamine, but it's not really a medication. I think it's not usually triggered by, I mean, the things that tend to increase the risk tend to be things that increase sympathetic activity. So you might wonder about sympathomimetic drugs of one sort or another. It's relatively unusual though for us to see that as the reason. Yeah.
Okay. And any comment on family history and genetics and how that might?
Yes, there definitely is. There is familial atrial fibrillation. So there are a number of genes that have been identified related to the connexin, which is a structural protein in the atrium, which have been associated with risk. So there's definitely families that have where atrial fibrillation occurs, and likely it's a genetic component, and that would be something to think of, particularly in younger people who are presenting with atrial fibrillation, who otherwise have apparently normal heart. There's a possibility that this is a genetic factor. In the end, from practical terms, how we manage it, it doesn't make too much difference. But nevertheless, I think at least at this stage, we don't have ways of targeting specifically the genetic reason for these.
And diabetes and central adiposity, does that sort of go along with?
Yes, I think that's right. So diabetes, well, diabetes itself may be a risk factor, but certainly obesity and metabolic syndrome, the patients who have that are at more risk. And I think in individual patients who have an episode of atrial fibrillation and have the risk factors of lack of exercise and being overweight, I think a lifestyle advice, the benefits of lifestyle change may well track to less problems with atrial fibrillation as well.
That's great. I think, thanks guys, we're getting some questions through, which is great. So keep them coming.
Okay, so as I think everybody knows, one of the real concerns with atrial fibrillation is the risk of stroke, and the risk of stroke occurs essentially because of stasis of blood within the atria, and particularly the left atrial appendage, because the atrium effectively isn't contracting. So the chaotic fibrillation of the atrium means that that it's not contracting, and then stasis causes blood clot to form. And this picture on the left there shows a thrombus within the left atrial appendage, which we can see. You can't actually see that with a transthoracic echocardiogram, so you can't see the atrial appendage. We can see the atrial size, but you can see it with a transesophageal echo. So this is looking at the atrium from the esophagus forwards, and so that's why, or predominantly the reason why, there's a risk of stroke. And interestingly, the blood clot tends to go to most other parts of the body without causing too much grief, but if it goes to the brain, it can cause a lot of grief, and we know that strokes related to atrial fibrillation have a much higher probability of being disabling than other strokes. And just on the right there's one treatment strategy. It's not the common or necessarily the best treatment strategy, but one treatment strategy for dealing with that risk is to plug the atrial appendage with an occluded device, and that's just showing one of the devices that can be used for that, and there may be indicated in the small group of patients who can't tolerate anticoagulation. But what the mainstream treatment to reduce the risk is an anticoagulant drug to reduce that tendency for blood clot to form there. And I think, thinking about it with the patient's point of view, it's particularly challenging because, of course, the patient feels perfectly fine. They're not aware and don't know if they're at risk of the blood clot forming, and so it really is a very important discussion to have with patients about this risk, and because it's only a risk that I guess the majority of people will not have a stroke, but when it occurs, it is particularly a devastating thing. So so that's a challenging discussion that needs to be had. Okay, so this is the standard score that's used to estimate approximately the risk of stroke. So this is the HAS-BLED score, and the idea here is that if actually you don't have any of these clinical risk factors, or you only have one, then the risk of a stroke is actually very low, and in that case it may not outweigh the downsides of anticoagulants. But if it's 2 or above, then the risk goes up, and I'll show you that in a minute. And usually most people believe, or at least the studies show, that the benefits overall of an anticoagulant outweigh the downsides. So these are the key risk factors: that heart failure or left ventricular dysfunction, and that's a risk because heart failure tends to cause higher atrial pressure and more atrial enlargement and more stasis in the atrium. Hypertension, age. So age greater than 75 scores 2 points. So if it doesn't matter anything else, if you're older than 75 and you've got atrial fibrillation, according to the HAS-BLED score, you should be anticoagulated. Then we've got diabetes, and then the next one is very important: a prior stroke. So if you've already had a stroke, then that's an indication in its own right to be anticoagulated. And then vascular disease, age 65 to 74 scores 1 point, and female sex scores 1 point, and that's because women tend to have a moderately high, all else being equal, have a moderately high risk of stroke, and so it's thought that if you have a woman has one other risk factor, then probably they should be anticoagulated. If they don't have any risk factors and that's the only thing for a woman, then usually anticoagulation wouldn't be recommended. So that's the HAS-BLED score, which is the clinical risk tool, and I think that should be considered in every patient. And the patient we've just discussed, she's age 72, so she would score 1 point for that, and she has hypertension, so she'd score 1 point for that. And we may not know about, and she's also a female, so she scores 1 point for that. So she's got at least 3 points, even if we don't know necessarily about some of the other things. She should be anticoagulated based on that.
But just a couple of questions relating to the HAS-BLED. We'll probably talk briefly about the greater risk for females. Is there any particular reason for that we know of, or is that just? Well,
that just comes out of the data. So what is the reason? I actually don't know. But that's what the data says. That the women, all else being equal, who have atrial fibrillation, have about a 30% higher risk. So
30% higher. Yeah. And the hypertension part of it, is that referring to the uncontrolled hypertension, or if they're nicely controlled?
No, it means if you've got hypertension if you're on blood pressure medication. Right. Or if your blood pressure is higher than 140/90. So that's the definition used. Yep. So the fact that your blood pressure is okay on medication does not, you still carry a higher risk than if you didn't have hypertension at all, and you should be on the anticoagulant.
Excellent. There's a couple of other questions coming through about what medications would be recommended, and we'll get to that shortly, I believe, so we'll probably carry on with that. Just a question about and additionally, sort of what age you would consider not prescribing.
Yes.
Which I guess we'll come to.
Well, that's a good question, and we should answer that question in a minute. Yes. Yeah. So left ventricular dysfunction is normally we say an ejection fraction of less than 40%. So a less than 40% is a level where where we know that there's a number of drugs which improve outcomes, like beta-blockers and ACE inhibitors, and it's a somewhat arbitrary definition, but that in simple terms is what we mean. In fact, but if you've got anything wrong with your heart, you also get 1 point for vascular disease. So vascular disease could include a prior myocardial infarction. I mean, I actually think you'd give a point for anything wrong with your heart, really. It's significant that, and then the LV dysfunction refers specifically to the systolic function, left ventricular function. So, probably a history of heart failure is a more important risk factor than LV dysfunction, which is asymptomatic. But these the tools are relatively they're just rough estimates to be fair.
Yeah, sure. And does this score apply to paroxysmal atrial fibrillation?
Yes,
as
well, that's another question that is relevant to a later case. But the key point, and it's a very important one, is that the risk of stroke is present even when a person has paroxysmal atrial fibrillation. In fact, it might, and that's very important because both patients and doctors think, well, they're a little bit hesitant about anticoagulant and they're in sinus rhythm now, maybe we don't need it, the risk is lower. Now, what's been found though is that those patients actually, what happened is that they did a study where they stopped the anticoagulants, those patients, because they thought they were going to be okay, and the stroke risk turned out to be really quite high.
Oh, right.
So we know that the flipping in and out of atrial fibrillation, you can imagine, the risk of the blood clot embolizing is actually greater probably when you change from the atrial fibrillation to the sinus rhythm. So suddenly the atrium starts contracting again, and you've got some fresh blood clot there, and that's when it goes off. So I think that's a very important point, that the fact that if you've got atrial fibrillation at any time, then you really should be treated the same, treated like the same as if you've got persistent atrial fibrillation. The risk in absolute terms is a little bit lower, but it's definitely still there. Yep. So the CHA2DS2-VASc score, and the CHA2DS2-VASc quantifies, the overall risks and should be considered.
And so that would also apply too. We've had a couple of questions about whether this would apply in a patient with AF as a result of an intercurrent illness. But I guess that...
Yes, well, that I agree that that's somewhat challenging because if you say, well, they've had an intercurrent illness, that really comes down to the question of how likely it is to happen again.
Sure.
Very often, though, that they do actually carry a risk of recurrence. So, for example, if you have a UTI or chest infection, get atrial fibrillation, those patients are actually at risk of recurrence. So unless there's a very clear-cut one-off thing, I would tend to quay on the side of caution.
Yep.
And these are the patients where we tend to see, that they, the handful of patients that I've seen who've sort of known about their atrial fibrillation, and they've ended up having a stroke, and you regret it afterwards. So I think there's a bit of caution about that.
Yeah. Sure. I think just one other thing about risk factors is whether smoking plays into it. It's not specifically mentioned in the scoring.
Yes. No, to my knowledge, smoking is one of the bad things that isn't a risk factor for atrial fibrillation or thrombo-embolic stroke. You think it probably would be, wouldn't you? Because it's has pro-coagulant effects and so on. Yeah. So it doesn't seem to feature, and I'm not sure why that would be, but yeah.
Okay. No, that's great. And I think we'll probably get on to answering the rest of the questions as the...
So this shows the estimated stroke risk depending on what your CHA2DS2-VASc score is. So you can see that as your CHA2DS2-VASc score goes up, your chance of having a stroke in that next year progressively increases. So I think this is important for two reasons. One is that if you, and this is a judgment here, and I think some individual conversation with the patient, but if you look at a person who's got a CHA2DS2-VASc of 1, they have a 2.8% or nearly a 3% risk of a stroke per year if they're not on an anticoagulant. Now that might seem low, but if that's a 50-year-old person and you look at that risk over 10 years, that's come up to a 1 chance in 3. And for that person, a stroke, it could have a devastating effect on their life. So I think that, some judgment is needed. It's not a simple cut of two. But then if you look, the other key point is if you start getting these high CHA2DS2-VASc scores, 4, 5, and 6, your annual stroke risk becomes incredibly high, above 10%. And I think, and over several years would be, I believe, unacceptably high. Now, this is important because often it's these patients who you tend to be much more cautious about anticoagulant because they tend to be the frailer patients who've got comorbidities and have reasons don't want to anticoagulant. So I think that just being aware that there is a graded risk, and as your CHA2DS2-VASc goes higher, your stroke risk really does get quite high, and that needs to be considered when judging the bleeding side. So I think the bleeding side is this is at the, so just before we go on to the anticoagulants, the low risk patient. So who is the low risk patient who on current guidelines probably doesn't need to be anticoagulated? So a person who's less than 65, they have no evidence of other cardiovascular disease. So in other words, they have low atrial fibrillation and they have no other obvious stroke risk factors. So those patients probably don't need to be anticoagulated. Okay, so I was going to go, I know people might want to talk about bleeding, but first of all, let's talk about the drugs, and then we can come back to the bleeding, and then there might be questions about the drugs as well. So these are the possible drugs that we might use to reduce this risk of thromboembolic stroke. So the first one is aspirin, or another antiplatelet drug, and that's got the advantage that it's pretty easy to use. You only have to take it once a day. It's widely used and people are happy with it. But the problem with it is it doesn't work, basically, or it only works a little bit. So the studies that have been done have been two. So the studies of aspirin or antiplatelet drugs against placebo have shown that it reduces the risk in relative terms by about a fifth. So it prevents about 1 stroke in 5. Now that compares to warfarin or oral anticoagulants, which probably prevent 4 strokes in 5.
Wow.
So and when we directly compare one with the other, the anticoagulant always wins. And excuse me.
Just for those of you wondering about the acronyms here, OAC is oral anticoagulant, and NOAC is.
Yes, so the oral anticoagulant. Yes, so I should have. You shouldn't use acronyms, should you? So OAC is novel anticoagulant, and sorry, OAC is oral anticoagulant, and NOAC is the widely used term for the novel oral anticoagulants, which include Dabigatran and apixaban. But they also go by the name of DOACs, which is direct acting oral anticoagulants, because I suppose after a while they're no longer novel, so you've got to say what they are. So they're probably going to be changed to the name of DOACs, which is direct acting oral anticoagulants. In other words, they don't act by inhibiting the vitamin K pathway. So warfarin is was the tried and true oral anticoagulant that's been evaluated and shown to be effective. And usually the target INR is between 2 and 2.5. But as everybody knows, it's a bit of a challenging drug to use. It involves blood tests and dose adjustments, and can be influenced by the diet and can be influenced by drugs. And also when it's compared against the NOACs or DOACs, there is a higher overall bleeding risk, and particularly intracranial bleeding, which is the worst sort of bleeding. But nevertheless, that's an effective treatment. And then the other anticoagulant that's now widely available and used in New Zealand is Dabigatran, and that has the advantage that you don't need monitoring. The dose is fixed, or at least it's fixed and can be adjusted according to bleeding risk and renal function age. But you can decide on the dose and give it. And overall, it has a slightly better risk-benefit ratio than warfarin. But it does have some side effects. I guess the biggest downside I think of Dabigatran is the GI side effects and problems when you have GI bleeding. So, indigestion, GI side effects. Very important to remember renal function. So with any of the novel oral anticoagulants, Dabigatran is 80% renally cleared. So that's when the problem occurs if you use a higher dose and there's renal impairment and the drug gets to a high level and the bleeding occurs. So renal function is important, and if you've got very poor renal function, you don't use it, and you don't use it if you've got a mechanical heart valve. So it's been shown that it doesn't stop the blood clot on the mechanical heart valve. So that's a very important point. And then finally, we've got the oral factor Xa inhibitors like apixaban and rivaroxaban, and they overall have a very similar risk-benefit ratio as Dabigatran, and they generally have the advantage of being pretty well tolerated. In fact, they don't have the GI side effects of the Dabigatran or Pradaxa, which is an advantage. Now, most unfortunately, though, they aren't currently funded, so that's a bit of a challenge to their use. So mostly we're talking about, I think, Dabigatran. And there are a few things related to the oral factor Xas. Again, you really the biggest thing really is remember renal function and a dose adjustment down for older people.
So a couple of questions about choices here, and a lot of questions actually about aspirin and patients either already on aspirin
yes.
for another reason, who then need to be anticoagulated for AS.
Yes.
Would you consider leaving them on aspirin as well,
yes.
or should it be a change?
Yes. Well, that's a very good question. I think that has to be very carefully considered according to the individual patient's circumstance. So the problem with aspirin is that if you just look at the bleeding rate for Pradaxa alone, it's not too dissimilar from aspirin. So we all often think, well, the bleeding with our oral anticoagulants is higher, but actually, somewhat surprisingly, it's not that different. But it certainly increases a whole lot when you put the two together. So more than doubles. So that excess risk has to be weighed against the potential benefits of aspirin. Now, there are some things that the anticoagulants like the Dabigatran are better at, and there are some things that the antiplatelet drugs are better at. And the biggest thing that the antiplatelet drugs are better at is stopping thrombosis on a stent. Right. So if somebody's had a recent stent, so you're talking particularly in the last 6 months, then before the stent has been endothelialized, then almost always they need to be on an antiplatelet drug. The Dabigatran or the oral anticoagulant will not stop the stent thrombosis, which doesn't happen very often, but when it does happen, it's a catastrophe. So in that situation, that would be one situation if you've had a stent in the last 6 months, that you would consider using both. Now, after 6 months, and certainly after a year, it would for many patients it would be reasonable to stop the antiplatelet drug and just go on the Dabigatran. And I think if you're calling and for stable coronary disease or atherosclerotic disease generally, and a person who's got atrial fibrillation, I would go for the oral anticoagulant first and the antiplatelet drug second. And I'd look to see if there's not a really good reason for the aspirin, stop it, because that will increase the risk of bleeding.
Sure, that's great. A couple of other little questions. Again, about aspirin, is there a dose effect that you would consider increasing the dose from 100 milligrams to gain an effect?
Yes, no, I don't think it's a dose. There's a significant dose effect. There is actually quite a bit of argument about what's the best dose of aspirin for reducing, well, for example, in patients who have coronary artery disease, is it better to go 300 milligrams, which is what the Americans tend to do, or 75 or 100, which is what the rest of the world do, and they're actually doing a study on that. But for practical purposes, it's a very small difference. So the antiplatelet effect, which comes from inhibiting the thromboxane enzyme, it occurs with a relatively low dose, and there's not further a blood thinning effect by increasing the dose, and you won't get the benefits that you get from an oral anticoagulant, which works in a completely different way, by cranking up the dose of aspirin. Yep. So I think the answer to that's probably no.
Okay, and another sort of group of questions are really relating to people who are either have poor renal function or are on non-steroidals for things
Yes.
like OA.
Yes.
And you know, the difficulty of choosing something appropriate in that situation.
Yes. Yes. So the poor renal function is actually a real challenge. In the trials, they found, you know, because they didn't use the novel anticoagulants below an eGFR of 30, but in the patients where they looked at above 30 or 30 to 50, which is moderately poor renal function, the bleeding risks were actually lower on the patients who were on the novel anticoagulants than the warfarin. So warfarin, even though people say we've got to use warfarin when the renal function is bad, is actually not a great, is not a great idea. So clearly the guidelines are you don't use Dabigatran or any of the oral factors, well, Dabigatran particularly when the eGFR is less than 30, and you definitely need to use a lower dose of 110 milligrams PD when it's less than 50. Now, and probably the problem is when your eGFR is lower than 30, your stroke risk goes really high as well. As your bleeding risk goes up and your stroke risk goes up, and you've got problems with managing the drug. So I think that's a real challenge, and I would consult your renal physician as to what the best thing to do, but there isn't an easy answer to that. Now, some of the factor 10A inhibitors, and like apixaban, are only half renally cleared, and I think it makes a lot of sense to look at them. But actually we have very limited data at the moment. So I think at the moment, the very poor renal function is a real dilemma, and it's not, we only have clear answers. But for the people who have moderately poor renal function, you can use the Praxbind. I think it's the best drug, but you need to be aware that the renal situations, if they become unwell, the renal function might go off. If they get some intercurrent illness, they become dehydrated. They need to be aware that there may be a bleeding risk because the eGFR is deteriorated temporarily, and keep a kind of check on it. That would be my thought.
And in terms of people on non-steroidals, would that influence?
Well, non-steroidals is another. I think is. Well, non-steroidals are a problem because, for many reasons. One is they increase the risk of bleeding. They can affect renal function. They can cause GI side effects, which might be confused with the Dabigatran. I think that what I would say is, but obviously there might be clear reasons why that they need to be used. So I think that it's just I don't have an easy answer for that. I think if they're on non-steroidals, they have a good reason for them. It's not a reason not to give them an oral anticoagulant to reduce the risk of stroke. You might want to consider omeprazole or an equivalent medication to possibly reduce the risk of GI bleeding. And you might want to consider, if the risk of bleeding was higher, a slightly lower dose of the anticoagulant. But I think that's a very individualized thing. I wouldn't say it's a reason not to use the anticoagulant.
Sure. So just a careful thought. And just a couple more questions about, is Dabigatran appropriate for valvular heart disease if there's not a mechanical valve?
Well, I think it is actually, but the one valvular disease where everybody has well, the guidelines still say maybe you shouldn't use it as mitral stenosis, which is relatively rare, fortunately, but untreated. So every other valvular disease is you can just treat like everybody else.
Yeah.
Now, with mitral stenosis, it actually is the condition that causes the most risk of thrombo-embolic stroke, because you've got this disease which obstructs the blood getting out the left atrium because of the narrowing of the valve, and that causes more stasis. And I think there's absolutely no good reason why they shouldn't work. But if those patients were not included in the trials, and that's the guideline. But there's discussion about that. But every other valve disease, mitral regurg, aortic valve disease, there's general consensus that you just treat them the same as everybody else.
Right. Okay.
But the mechanical valves, not, because as I said before, the mechanical valves, if you've got a mechanical valve, it doesn't stop the blood clot forming on the valve. If you've got a tissue valve, like a tissue valve uses, then they're fine.
They're fine. And what, just a couple of comments about warfarin. General theme of questions coming through is the feeling that there's a feeling of a known quantity with warfarin and a feeling of safety about prescribing it versus Dabigatran, which is new. but I guess what you're saying is you consider it as a first choice.
Yes, no, I think I can understand that, but I think there was a lot of concern with the Dabigatran earlier on because it was unfamiliar with it, people were unfamiliar with it. I think the most reliable evidence actually comes from the trials, and that they show that well, they have it as effective at preventing a stroke with less bleeding, or more effective at preventing stroke with the same amount of bleeding. That if people do have a major bleed, they actually have better outcomes when they're on the Dabigatran than the warfarin, even though there was concern that the warfarin, you can theoretically reverse it more easily. In fact, as I come to in a minute, there is now a drug that allows us to reverse Praxbind very quickly. So actually, that's probably in favour of Praxbind now, if need be. I think though that if a patient is on warfarin and their INRs are reasonably stable, so big fluctuations in the INR are a risk factor for bleeding and of stroke. So if the INR control is difficult, then that would definitely weigh towards choosing Praxbind or a novel anticoagulant. But if they're stable on INRs, they're happy with the warfarin, I don't think there's any reason to change.
Yeah, sure. And any comment on the effectiveness of warfarin below an INR of 2?
Yes, well, they did do a trial where they looked to see if low dose warfarin was effective, and it wasn't.
Right.
So we do know that you really need to aim to get the INR above 2, and running it below that's probably not going to work. The interesting thing though is that it seems to be, even though the average patient might be out of the therapeutic range for maybe 20 to 30% of the time, it still seems to work despite that. You'd think that if they were out every time they're out of the therapeutic range, it wouldn't work. But despite that fluctuation, although that's probably one of the reasons why overall the newer anticoagulants are better, because there's a more consistent level of anticoagulation. And if you have got patients whose anticoagulant INRs are pretty stable, then they do very well. Yeah.
Well, that's great. Just comment about the cost of Dabigatran and.
Well, that's a mystery. I mean, I think the drug cost will be higher than warfarin, which is virtually nothing, but the secondary costs of warfarin would be quite high, and the analysis that have been done have suggested that actually it's probably cheaper than overall, because by the time you factor in the cost of all the INRs, the monitoring, and the stuff that you do to keep people in the range, and then all this, so it probably is not. But and Pharmac have apparently struck a very good deal. So I personally think that I wouldn't be concerned that the cost is a decision and is a factor for us in New Zealand for that choice. Having said that, the drug that stops the bleeding is very expensive. That costs about $4,000. I'll come to that. So you don't use that without a good reason.
Oh, this links nicely into one of the questions that we've had specifically about the score.
Yeah. So the other thing that we need to think about with an oral anticoagulant is the risk of bleeding, and that probably that's the bleeding that you tend to see. Well, it occurs, a significant minor bleeding will occur, even will be the most common side effect you'll see from an oral anticoagulant, and a major bleed might happen almost as much as a stroke. The thing about a bleed though is that it very rarely has a devastating lasting effect, with the exception obviously of an intracerebral bleed, which would be devastating. But a stroke can have a devastating lasting. So when you balance the pros and cons, we can normally manage bleeding, even though we don't like it, or which can be a problem at the time. But a stroke is bad for a long time. So that's one way of thinking of it. But there are various scores to try to assess whether a person's got a higher bleeding risk, and the HAS-BLED score is one of the most commonly used ones. But it's very interesting that when they've looked at the HAS-BLED score, actually is a very good risk, quite a good predictor of the risk of a stroke, and the CHA2DS2-VASc score is actually quite a good predictor of the risk of bleeding. They really tend to sort of track together. So what we've learned, and what is currently recommended, is that you take an individual approach, and what you do is you focus on what can I identify, or what things I can do for my patient to reduce the risk of bleeding. and some of those things we've already discussed, and then as long as the bleeding risk isn't too outrageous, you treat them. That's the attitude, even if the scores are high. So these are the things but considering what can you do is very important. So uncontrolled hypertension is an important risk factor. So treatable, get the blood pressure down. Although obviously you've got to be careful that if you've got to take a gradual approach, because if you suddenly bring it down, they might fall over and bang your head. So that wouldn't be good. Previous bleeding is very, you can't take a blanket approach to that because it depends on what the bleeding was, and was the reason fixed, or is it going to likely recur, and so on. Anticoagulant dose is an important consideration, so you can always adjust the dose downwards if you're concerned about the bleeding risk. And obviously that's very important. Renal function. Renal function is a major driver of the blood levels and the bleeding risk. So if they've got renal dysfunction, it's very important to reduce the dose. And that relates to the intensity of control of the anticoagulants. So poor INR control, you either try to do something to improve the control, get people in the therapeutic range more, or switch them over to Dabigatran if that's possible. And then antiplatelet drugs we've already discussed. So if you can stop the aspirin, you shouldn't stop the aspirin if they had a recent stent, but most other things you can probably stop the aspirin. And then we've talked about non-steroidal anti-inflammatory drugs, and in theory, at least, if people drink too much, they can theoretically advise them to stop. So that would be another a possible thing.
That's great. Is there any, so I just noticed a question before, and it might go to the dose, through what we just talked about with dosing with the anticoagulants, with a question about 75 milligrams of Dabigatran twice daily, and if there's any thought to the start low, go slow approach, whether there's any.
Well, I think that's a very, very interesting idea. I think it would be, I think 75 milligrams BD in a frail elderly person with low body weight and poor renal function would be better than not giving them anything. And but the problem we have is that there's very little data. So you're using your clinical judgment. But my judgment would be it's a good idea. Yeah, yeah. And just while it's on this, we've got the slide. This is this remarkable drug or monoclonal antibody that can directly bind, has a high affinity for Dabigatran, and it prevents it from binding to the thrombin. And the research was done on that in New Zealand to show that it was very effective at stopping bleeding in people who had major who are on Dabigatran and came to hospital following a trauma or needed urgent surgery, and the drug needed to be reversed. So that has been shown to be highly effective. The problem is, as I mentioned before, it's pretty expensive, as most monoclonal antibodies are, but it's there for the serious bleeding. For more minor bleeding, the bleeding can be managed by withholding the dose of the drug, and then it is out of the system. Well, it might take a day to get out of the system. Right, so that's one important thing to remember about the Pradaxa compared to warfarin, for example. So warfarin takes a few days for the bleeding effect to be there, and then and a few days for it to go away. With Pradaxa, once you start the drug, it'll be pretty well effectively working within a few hours. So that might be relevant for how quickly you start it after you've had a tooth extracted or something. You've got to be aware that once you start it, it'll be working in a few hours' time.
Yes, that's good to know. With someone who's had a stroke and on aspirin already, would they be a candidate for Dabigatran on top of aspirin, or would that again be a situation?
No. I think that if you've had a stroke, there's a particular concern with the combination of antiplatelet drugs and anticoagulants that have a risk of intracranial bleeding. So I think in that situation, well, you might need specialist advice. But I think that mostly, if they're in atrial fibrillation, there's usually a period of time where no anticoagulants is given, maybe a week or so, and then you would restart the oral anticoagulant, but not use an antiplatelet drug as well.
Right. And any suggestions for bridging? For the example you just talked about maybe a tooth extraction, someone on Dabigatran.
Yes, no, I think we've learned that you're better not to bridging generally in better not to bridge. So you're basically going to decide how long you want to stop for, maybe a couple of days before something's going to be a big bleed, and then decide when to restart. Now, and I think, but not try to bridge in the middle. So that just requires a judgment according to the bleeding risk and so on.
And I guess following on from the, quick on and off effective Dabigatran, that must go to compliance being important. So,
yes, well, I think that compliance is a really important. I mean, we know that preventive type medication. So the challenge here is it doesn't make you feel any better. So so why would you take it? So I think that the compliance is huge, and we know that the medications that we generally recommend for reducing the risk of cardiovascular disease that don't actually make people feel better, they haven't got a good track record for compliance, and that maybe up to 50% of people for one reason or another coming off the medications after time. So I think this is a real challenge, and I think that it's, and one of the challenges, and another challenge, with warfarin, you knew whether they were taking it or not because you could see the RNA result, but that actually you may not. So I think this is really, it's really about engaging the patient and hopefully them understanding the nature of the problem and why this drug is given, even though you're feeling okay, and even though there's a bit of a downside with bleeding, but reassuring them that the balance, there's very good information that shows that the balance of benefits and risks is in favour of the anticoagulants. In fact, the studies show a lower mortality, which is pretty consistent too, which is, so I think, it's one of the areas where, you can argue about, certainly have other arguments about the benefits of preventive medication in different people, statins and people who are otherwise well, that's, but in this group of people, there really is, my view is that, that they're an area where the preventive medication, there's a strong rationale for it.
Yeah, sure. That's great.
So the next thing we might think about, I'm not sure if we've got it, we've got other questions on anticoagulants, or should we talk about some other things?
Oh, actually, yeah, there is one question just about monitoring, I guess, should, considering levels of Dabigatran and screening, coag screening.
Yes, so it is possible to measure the levels, and I guess, I mean, mostly it's not thought to be necessary, but there might be occasional individual situations where you want to know that they're taking it, or whether you want to know if it's present. It can be done. I'm not sure. It's not. I think it has to only be done in big hospitals, though.
Yeah, sure. We might need to press on just to get through the slides. And
yes, I'm sorry. We'll get halfway through and
we'll have to. As we go.
Yeah. So the other question in this, the other question we might have with this patient is the question of heart rate control. So should a drug be used to slow the heart rate? So there was a very interesting work. I mean, there's two reasons why you might want to slow the heart rate. The first is symptoms. So the symptoms you get from the atrial fibrillation tend to be worse when the heart's beating very fast. So both the sensation of the palpitations, and because the faster the heart rate goes, the less efficient the heart is. So symptoms related to shortness of breath and dyspnea tend to be greater. Now, mostly there's the benefits are particularly when the heart rate's above 110. So if the heart rate's above 110, the recommendation is you need to do something to slow it down. And below that, there's not such strong evidence, but usually we say try to get the heart rate below 90. And the medications for slowing the heart rate are drugs that slow the conduction through the atrioventricular node, and the most commonly ones we use are the beta blockers, so metoprolol or bisoprolol, or calcium antagonists. And it's really an individual thing as to which one you choose. It depends on the patient and possible side effects and so on. And you might want to, if the patient's not particularly symptomatic, you might want to start slow and gradually build up. And one important thing is to remember that if you use two drugs together, that can have quite a big effect. So more than each of them to get together. So while sometimes it is used, if you can't get the rate down with just one of the medications, just be aware that when you add it in, it might have a bigger effect than on slowing the heart rate than you otherwise thought. And the downside, obviously, to overdo it is the person becomes bradycardic and you have problems with blackouts, for example, or fatigue due to excessive bradycardia. So the other reason to slow the heart rate other than symptoms is to prevent this condition called rate-related cardiomyopathy. So if the heart's racing very fast for a prolonged period of time, it basically gets tired and it dilates and then doesn't contract so well. So that condition, so to avoid that condition, we slow the heart rate, and when you slow the heart rate, if there is the rate-related cardiomyopathy, it usually recovers over a period of several weeks. So that's that. So, should we talk about the second case?
Yeah.
So this is a 48-year-old man, so this is a different perspective of atrial fibrillation, who's normally well, who presents acutely with rapid palpitations present for about 2 hours. He feels pounding in his chest and he's slightly lightheaded unless he's sitting doing nothing. And when you examine him, his heart rate's 120 and his blood pressure is 115 on 90. And well, you listen to his heart and that sounds pretty normal. So I guess the first question, as with any patient, is what is the diagnosis? So it sounds like a tachycardia, but we need to get an ECG to confirm it. So here's an ECG of a person who's in another ECG of rapid atrial fibrillation. So you've got the two leads there, and you can see that there's irregular intervals between the QRS complex, and you can see some things that look like a P wave, but no consistent pattern. So that's atrial fibrillation. But sometimes it might be this, which is a supraventricular tachycardia. This might be an atrial tachycardia or atrial flutter. I'm not sure, but it's regular and rapid. Okay, so the question is, what do you do? And these are things you might think about. First of all, how well is the tachycardia tolerated? So is the patient, if he's just complaining of palpitations, that's one thing. If he's got short of breath or dizziness or chest discomfort, then that's quite another. That means that we really have to take action more immediately, and referral to the emergency department or cardiology would be appropriate. If he's not too symptomatic, well, there are a number of things we think of. And what possible treatments are there? So in this case, what we'll be thinking of is, we do need to think of all the things we thought of before. So why has the patient got atrial fibrillation? Is an oral anticoagulant needed? Do we do rhythm or rate control? But the immediate question, I guess, here is he's only been at 2 hours, so there isn't immediate concern of the stroke risk for the first day or two. So the real question is, how do we get him back to sinus rhythm? And then we can think about why it might have occurred and what the treatments might be. So the possibilities for getting back to sinus rhythm would be drugs like flecainide or amiodarone. So normally in the hospital, at least we'd give them as an intravenous bolus. But if a person was recurrently getting atrial fibrillation, they may be reasonable to take the flecainide at the time, maybe together with a beta blocker to slow the heart rate, and then just be patient and allow the heart to go back to normal. If it's the first time, I think you definitely want to refer to the hospital. And then cardioversion is the other way of doing it. So cardioversion basically involves an anesthetic, but it shocks the heart and abolishes all the arrhythmia, and then allows hopefully the normal sinus rhythm to come through. So that could be done. But very often a person who gets paroxysmal atrial fibrillation, it will actually flip of its own accord if you're just patient. So there's a balance between being patient and hoping it goes back against cardioverting. You don't want to wait too long before you cardiovert if it doesn't go back. So that's just a judgment decision. And then there's the question of the other strategy is just control the rate and allow things to settle down. So again, you use those drugs to control the rate, so a beta blocker or diltiazem. So those are the sort of thoughts that you might have when seeing the patient. And then, but we've got to think of all. So the first thing is, how is the arrhythmia tolerated? So are there associated cardiac symptoms which are related to the rapid rate? It does make a difference if this is the first time you're seeing them or whether it's a track record. You know, obviously if there's a track record, it's a recurrent offender, you're likely to know about the underlying cardiac disease. You're likely to know the things that worked and didn't work in the past, and that can guide treatment. Is there evidence of some other acute medical problem that's triggered the episode? Does the patient have known cardiac disease or cardiomyopathy or comorbidity? And then this business of rate control. So if the rate's above 110, normally we want to be giving a drug like a beta blocker or maybe diltiazem to slow the rate down. And then is the patient at risk of stroke? So that applies for paroxysmal atrial fibrillation as well as persistent. In this case, he's only 48, so it does depend on whether he's got other disease. But in the very short term, the risk of stroke would be low. But nevertheless, normally it's something to think about, I think, with any patient you see with atrial fibrillation.
That's great.
So somebody's asked, is he a candidate for ablation? And well, he might be, but usually you would think about that down a little bit down the track, so you get it back to sinus rhythm. So ablation is actually quite a prolonged procedure. It's quite a challenge. It takes a number of hours. But if the person a young person has recurrent atrial fibrillation, they don't have any other structural heart disease. Very commonly, the atrial fibrillation is due to excitable foci, if that's the right term, in the pulmonary veins, and isolating the pulmonary veins from the left atrium, which is what an ablation does. Stops the triggers for the atrial fibrillation and can be very effective. So it's the young people who have episodes of paroxysmal atrial fibrillation that are highly symptomatic that would be the candidates for ablation. That is true.
Oh, that's interesting. Another question just about, I guess, the acute management of this, whether the prescription of stat fluids, giving a litre straight away for these acute presentations of fast AF is of any benefit.
Yeah, I honestly don't know. It doesn't seem to make much sense to me, except to say that sometimes atrial fibrillation is triggered by, we quite often see it triggered by being out on a hot day and maybe being a bit dehydrated, and so in that sense it might be useful. I think mastery activity and watching waiting is not such a bad approach. So that's one way of doing something and not doing something, if that makes sense.
Yep.
And waiting to see what happens.
Yeah, sure. And the idea about flecainide, someone's just commenting that they're more often than not being encouraged to stop it rather than start it.
Yes, well, flecainide is you have to be very careful about flecainide because flecainide can be very effective at reducing arrhythmias like supraventricular tachycardia or atrial fibrillation. But as the dose goes up, it actually can cause arrhythmias and actually can cause more serious arrhythmias than the one you're trying to fix. So there's a very small risk of Torsades point, for example. And when they did studies of flecainide in patients who had a myocardial infarction, the mortality was actually higher. So we're very cautious about using flecainide in people who have underlying structural heart disease. I mean, it can be used, but we're certainly cautious. Now, but for a young person who's got paroxysmal atrial fibrillation, their heart's otherwise normal, flecainide is actually quite an effective drug at stopping the atrial fibrillation. And so as long as the dose is okay and the therapy is in the normal range, it's a reasonable strategy. And then the other strategy you can use, the problem with it, if somebody gets only an episode once, twice a year, you have to take it every day. It's quite a lot of taking a drug. The other way to do it is to take it when you get the episode. But the downside of that is obviously it takes a little time to work. But if the irregulars, the atrial fibrillation is not too badly tolerated, then that's okay.
Sure. And any role for a beta blocker in that similar way?
Yes, a beta blocker, again, that's the other strategy. So a beta blocker will slow the heart rate, and a lot of the symptoms are due to a rapid rate. In fact, a beta blocker, if there's a rapid rate, is a good idea anyway, because the flecainide doesn't tend to slow the rate so well. So I think slowing the rate, if it's fast, it does a lot to relieve the symptoms. It's not clear that it flips back to sinus rhythm more quickly than normal, but often that will happen spontaneously anyway.
Sure. Okay. And any comments on amiodarone and when you would think about?
Well, amiodarone is probably actually the most effective antiarrhythmic drug that we have for atrial fibrillation, and I think if somebody's got paroxysmal atrial fibrillation, and definitely if they've got underlying structural heart disease and we don't want to use flecainide, amiodarone would be a consideration. The major problem with amiodarone is the risk of side effects. It's a drug that has side effects which can be quite important, and those side effects tend to occur. It's a very unusual drug that sort of accumulates in the body over time. So the side effects tend to get more, the longer you're on it, and the higher the dose, the more likely you are to get side effects, and they include sort of photosensitivity and suntan and burning, and much more easy than normal, but occasionally it can cause much more serious side effects, pulmonary disease and liver disease and so on. So I think amiodarone, my view is that you definitely want to that should be in discussion with a cardiologist when amiodarone might be used. But it certainly is a good drug for stopping atrial fibrillation.
Sure. Couple of comments about using a beta blocker as a sort of as required, and if you were to do that, what dose you would suggest and what
Well, so I would use the shorter acting beta blocker because the sustained release would obviously take too long to be absorbed. So, and I would, well, it depends a little bit on the patient and what they might have had before, but I'd be thinking of the top roll 50 milligrams and then repeating it after a couple of hours, something like that. Yeah, if there was no contraindication. Yeah.
Oh, that's great. Might need to move on. Just thinking about the time here. So.
Okay, so this is the last patient. So a patient has a history of palpitations, but when you see them, they're well, and actually you do the ECG and sinus rhythm. So the question is, what's the diagnosis? What's an atrial fibrillation, and how do I find that out? So that's, I guess the history might be helpful. So you try to get a history of the palpitation. So if it's sometimes the history of the heart sort of jumping around all over the place and starting suddenly and lasting a reasonable length of time and then stopping, might help you to distinguish it from, for example, ectopic beats, which would be which normally feels like a missed beat more commonly. That might help you, but the bottom line is we really need to try to capture the diagnosis, and it is important because these patients might be, if they are getting atrial fibrillation, they're at risk of having a stroke, as we've said before. So I think one of the things that we've found very useful in recent times is these phone apps which allow people to record their ECG when they have the symptoms on the phone. So this is a LiveCore device which you can just get for a little bit under $200, I think, and it allows people to just record an ECG rhythm strip on the phone, and then they can download that and show it to you or to the cardiologist when they have the symptoms. So that is one strategy. You could do that. The patient could get that if they were up to that. The other thing is to encourage the patient to see you come straight in when they get the palpitations if they last long enough. Obviously, not just to sit on them and wait for the next appointment, and to do the ECG at that time. So one way or another, it's quite important to make the diagnosis, because I don't think you can start anticoagulants or be guided by treatment if you don't really know what the diagnosis is. So I think that was a short case, that one.
Yeah.
So we're almost at the end. So maybe we could just see if there are any other questions, and then.
Yeah, there's a couple we haven't answered really. I guess firstly about the mechanism of the thrombus formation and how long that might take, and actually just more practically how it makes its way from the right heart right through to the brain without causing trouble along the way.
So it doesn't come. So the thrombus can form in the right heart, but if it's in the right heart, it'll go to the lungs, unless there's a hole in the heart somewhere, like in the atrial septum. So the thrombus that causes a stroke comes in the left atrial auricle. So it's both the atrium that are fibrillating, but it's the left side that's the problem. And then and it's in the auricle. So the auricle thrombus in the auricle then breaks off, and well, theoretically it can go anywhere in the body, but it surprisingly, quite surprisingly, it doesn't. Sometimes it causes a problem if a big clot forms. We sometimes see a blood clot that's going down the leg and causes an ischemic foot or an ischemic arm or ischemic gut. But the most, and presumably it's because the brain is so much more sensitive to sudden block in blood supply, that's where the devastating manifestations occur. Yeah.
And any ideas on sort of the time course of that? I guess that's getting at the, decision of...
Yeah, so the risk is thought to be very low if the person's been in atrial fibrillation less than 48 hours.
Right.
So if it's under 48 hours, usually, for example, that's relevant for when we cardiovert. So if we do a cardioversion, if it's less than 48 hours, we would normally do it without having the person on an anticoagulant.
Yep.
If however, we see somebody and we've decided we want to cardivert them, but they've been on atrial fibrillation for more than 48 hours, we would recommend that they're anticoagulated for 3 weeks. That's the recommendation before the cardioversion. So yeah, I think that's not an absolute thing. I suspect. I think the blood clot probably can form quicker than that, but I guess the bottom line is it does take some time to form after the atrial fibrillation has occurred.
Sure. Any comments? I guess there was some comments earlier too about deprescribing, particularly in elderly, frail.
Yes. No, I think that they are the most. They're really challenging to know the balance of benefits and risks in old, frail people, and I think it really comes down to clinical judgment in the end. I guess what I'd say though is that mostly we've overemphasized the bleeding risk. One of the things is that the risk of bleeding related to falls is probably overemphasized. That risk is actually much lower than what we perceive it to be. But I think that the whole issue of people are in care, or they have dementia, or there are other factors which would influence might influence the overall treatment strategy, and I think that really comes down to a clinical judgment. But one question to say is, when I'm weighing all these things up, but the patient had a big stroke, would I feel that I'd done the wrong thing? But that's it's a hard decision. I don't know what the right. That's obviously a challenge that's difficult to answer, and it has to be individualised.
Yeah, sure. Question about that final case, whether it would be appropriate to consider Holter monitoring or an event recorder.
Yeah, so the problem with the Holter monitor is that the Holter monitor is put on usually for 24 hours or 48 hours at the most, so the chances of getting atrial fibrillation during that time are really low. The event monitor would be better, but there's quite hard to access. So I guess that's the attractive thing about that live call monitor or some sort of phone device, is that the patient just, they're not, the cost of that is actually less than the cost of actually doing an event monitor. So that provides a way for the patient to be able to do it themselves. Assuming they've got a smartphone and can do it, but that's the attractive thing about that.
Are they something that could be potentially purchased by a practice?
No, I actually think they'd be very useful, because the other thing they're useful for is actually just doing a very simple 30-second screen for atrial fibrillation. So if you checked for atrial fibrillation on every patient who's over 65, about 3 to 5% of your patients will have atrial fibrillation.
Oh wow!
And so if you've gone for a year or so without checking their pulse, it's actually more reliable to do that. If you just get that, it's quicker than the blood pressure. And so I actually think it's might be quite a useful thing. Obviously, for the patient, then, well, you could lend them just the cheap phone to be able to do it. I suppose that would be another way of doing it. That would be cheaper than a dedicated event monitor. I think.
Yeah, sure. Oh, that's great. Probably just wrapping up soon, but just a couple of last questions, and it occurred to me that I haven't got the camera on, so you'll be able to see us again shortly, I think, if I've done it right. If someone's having paroxysmal AF, I guess we've sort of discussed that, whether or not the stroke risk is lower if it's only occurring infrequently and for short time.
Yes, so it is lower, but it's still there, and it's definitely, and they're the ones, as I said, that we end up thinking we're okay, and not being. So
Yeah.
so it does seem that people actually are having atrial fibrillation they're not aware of quite a lot of the time.
Still there, and I guess actually that sort of answers another question, which is about if you're not certain about the length of time that the AF's been there before you discover it.
Yes, you've got
that
to
influence your decision.
Yes, yes. Well, you've got. Well, I think if it's usually if you're not sure how long it's there, it's because that's not causing too many symptoms. So if it's causing a lot of symptoms, it's usually obvious when it starts. But if that's the case, then you assume it's been there. I think you've got to assume it's been there a while and act accordingly.
Yeah, sure. No, that's great. I think we've almost covered most of the questions actually, so we might be about ready to just
okay.
wrap up.
Well, thanks much. I was going to mention to people that I am involved in doing a research project of trying to provide simple advice to patients and to doctors in primary care managing patients with atrial fibrillation with BPAC. So the real challenge is that every patient is different. There's often many things to consider when balancing the treatments, and we're trying to learn better ways of trying to do that. So we'll provide some information to doctors. Hopefully some of you would like to take part.
Exactly. That sounds really great.
And
look into there. And yeah, just to mention the next webinar, keep in mind, Tuesday the 6th of June we'll be discussing hepatitis C with Dr. Ed Gain, so a topical subject. But for now, thanks very much for joining us.
Okay, thank you very much, Vicky, and thank you everybody for all your
thanks for all the questions.
Challenging questions. I think you might have about 100 of them.
Exactly. Look, thanks very much for taking part.
Okay, thank you.